Welcome to the deep dive. Today we're tackling a really specific but super important topic, arterial thoracic outlet syndrome.
That's right. And we're using Rutherford's Vascular Surgery and Endovascular Therapy, the 10th edition, as our main source here, a real heavyweight text.
Absolutely. So our goal for you today is pretty straightforward. Get a clear picture of arterial TOS. What is it? What causes it? How do you spot it?
And crucially, how it's treated. We want to cut through some of the medical jargon for you.
And there are some surprising bits, like the fact that that's actually the least common type in adults, but often the most serious.
Yeah, that contrast really tells you something, doesn't it? It highlights why understanding this specific type is so vital.
Okay, so let's dive in. Arterial Thoracic Outlet Syndrome, or TOS. What exactly are we talking about?
We're talking specifically about the subclavian artery being compressed. That's the big artery running through that narrow space between your collarbone, the clavicle, and your first rib.
And a key thing right off the bat, our source material is pretty clear that if this type of TOS is causing symptoms, well, surgery is usually on the table.
It really is. Unlike maybe some other forms of TOS where you might try conservative things first, for arterial TOS, the indication for surgery is much stronger.
And there's a typical way this progresses, isn't there? It's not just simple squeezing.
No, it's often a sequence of events. First, you get that external pressure, the compression.
Right.
Then, downstream from that narrowed point, the artery can widen. That's called post-stenotic dilatation. Think of a kinked hose bulging just past the kink.
Ah, okay. Makes sense.
And that weakened bulging area can actually turn into an aneurysm, a ballooning of the artery wall.
Which sounds dangerous.
It can be. And on top of that, clots, or thrombi, can form in these damaged or aneurysmal areas.
And those clots can break off.
Exactly. That's secondary embolization. Little bits break loose and travel down the bloodstream, potentially blocking smaller arteries in the arm or hand.
Wow. And this isn't exactly a new discovery, is it? The history seems quite interesting.
It really is. Rutherford suggests this might actually be the first type of TOS ever described, maybe way back in 1831.
1831, that's incredible.
And get this, the first surgery to remove a bone abnormality, specifically one causing a subclavian aneurysm, was done in 1861.
So they were connecting the bone structure to the vascular problem even then.
Pretty much. Though it had different names back then, like Nafziger syndrome, before the term thoracic outlet syndrome became common. It shows the core principle, fixing the anatomical issue, has been around a long time.
So let's talk about those anatomical issues. What's the root cause here?
The overwhelming factor in almost all cases of arterial TOS is some kind of bone abnormality. That's a really key point.
Like cervical ribs, I've heard those.
Yes, cervical ribs are a big one. But interestingly, the type often seen in arterial TOS tends to be different from those sometimes linked to nerve compression, the neurogenic type.
How so?
Well, in arterial TOS, these cervical ribs are often more substantial. They might extend further out and even partially or fully fuse with the first rib below them.
So like a more solid, bony structure pressing on things.
Exactly. And because of where they sit, they tend to push the subclavian artery forward.
Creating a pinch point.
Precisely.
Yeah.
Squeezing it between that cervical rib, or the first rib, and the anterior scalene muscle, which sits in front. The text mentions it often injures the underside, the inferior wall of the artery.
And that constant squeezing, that injury, what does it lead to?
Well, as we said, that post-stenotic dilatation, the widening,
Yeah.
that can progress to an aneurysm.
Right, the weakened bulge.
Or, even without a full aneurysm, the chronic damage to the arteries inner lining the intima can create rough spots.
Where clots can form.
Yes, leading to those emboli traveling downstream, or sometimes even a complete blockage, a thrombosis, right there in the subclavian artery.
The book gives some numbers on how common these different bone issues are, right?
It does. Table 125.1 gives a breakdown. Cervical ribs are the most common, found in about 64% of arterial TOS cases.
Okay, that's significant.
Then you have anomalous first ribs, meaning they're shaped irregularly. That's about 17%.
Still quite a chunk.
Then fibrocartilaginous bands, tough connective tissue straps, around 11%. And things like old clavicle or first rib fractures causing compression, maybe 7%. And rarely, an enlarged bit of the C7 vertebra, about 1%.
So overwhelmingly, it's some kind of structural, bony thing.
Almost always. That's the main takeaway for the cause.
Okay, so who typically gets this? Is it common?
Well, its frequency in the general population isn't really defined, but it's definitely a small subset of all the TOS cases that end up needing surgery.
like a small percentage.
Yeah, the text mentions studies showing numbers like 3%, 4%, maybe 6% of surgical TOS cases. So not the most frequent reason people have TOS surgery.
But there's an interesting point about younger people.
There is. Intriguingly, it seems relatively more common in children and adolescents compared to adults. Maybe 12% up to even 32% of TOS cases in that age group.
Huh. Why might that be?
It's not entirely clear. Maybe younger people are more active,
Mm.
and that activity combined with an underlying bone issue brings symptoms on earlier. Or maybe it's just detected more readily.
And for adults, who's the typical patient?
Usually young, active adults. The average age mentioned is often in their 30s to mid-40s.
Male or female?
Slightly more common in women,
Right.
but not by a huge margin. And importantly, there isn't usually a family history connection.
So it's more about having that specific bone structure or maybe a past injury.
Exactly. That association with bone anomalies or trauma is really strong. And the data backs it up. One study showed cervical ribs in 60% of arterial TOS cases compared to just 2% or 9% in venous or neurogenic types.
60%, that's a big difference. Okay, so if someone suspects they might have this, what are the signs? How does it present?
Well, the history and the physical exam findings can be very suggestive, but the textbook stresses that you really need objective tests to confirm it.
What's the most common symptom picture?
Often, it's hand ischemia, basically, not enough blood getting to the hand. This is frequently due to those emboli we talked about, either a larger clot blocking the brachial artery further up the arm, or lots of tiny microemboli showering down into the hand and fingers.
So cold hands, pale fingers, that sort of thing.
Yes, exactly. But it doesn't always start so dramatically.
What are the earlier signs?
It could be more subtle, like arm pain that only comes on with exertion using the arm. Or maybe unilateral Raynaud syndrome, just one hand, showing those typical color changes and numbness with cold or stress.
And if a big clot forms in the subclavian artery,
Then the pain can be pretty significant, moderate to severe.
can it be found accidentally?
Sometimes, yes. An asymptomatic subclavian artery aneurysm might just be picked up during a routine checkup or imaging for something else.
And the worst case scenario.
Very rare, thankfully, but potentially devastating. A clot could travel backward, retrograde, up into the artery supplying the brain and cause a stroke.
Wow, okay. So when a doctor is examining someone, what clues are they looking for?
Well, a young person with symptoms just in one arm is a big clue. They'll check pulses carefully in both arms, compare blood pressures.
Why compare blood pressures?
A significant difference between the arms could suggest a blockage or narrowing on one side. They'll also listen with a stethoscope over the collarbone area, the supraclavicular fossa.
Listening for what?
For a brute, that whooshing sound of turbulent blood flow through a narrowed artery. It might only be heard when the arm is moved into certain positions.
What else might they find?
They might actually be able to feel a cervical rib or feel a pulsating mass if there's an aneurysm. And looking closely at the hand might show signs of those microembolial, the pale or bluish fingers, or tiny splinter hemorrhages under the nails.
Okay, so you have the symptoms, the physical exam.
Yeah.
How do doctors confirm the diagnosis? You mentioned objective tests.
Right. It's fundamentally a clinical diagnosis
Yeah.
based on the whole picture, but tests are crucial support.
What about those maneuvers, like the Adson test, putting your arms in funny positions?
Yeah, those provocative maneuvers. The book points out they're not very reliable for arterial TOS. Lots of healthy people will have their pulse diminish during those tests.
High false positive rate?
Exactly. Up to 57% in some studies mentioned. So just because your pulse weakens doesn't mean you have arterial TOS.
So what tests are useful?
Non-invasive vascular lab studies are a good starting point. Duplex ultrasound is key.
Using sound waves to see the vessels.
Right. It can show an aneurysm, maybe sluggish or blunted flow patterns, or areas where the blood flow velocity is really high, suggesting a tight spot, a stenosis.
Does it have limitations?
The collarbone can sometimes get in the way, blocking the view of parts of the artery. But often, significant issues can still be seen. The text notes a velocity over 240 centimeters might indicate a fixed narrowing.
But you have to be careful with positioning during the ultrasound, too.
Yes, same issue as the physical maneuvers. Doing compressions during the ultrasound can also create false positives in about 20% of normal people.
Okay. What else in the vascular lab?
Things like pulse volume recordings or segmental pressures. These can help localize where a blockage might be, especially if emboli have traveled down the arm.
How does that work?
They measure blood flow or pressure at different points. If the waveforms in the fingers really drop off during compression maneuvers only on the affected side, that suggests dynamic compression. If they're just weak all the time, That points to a more fixed, serious problem.
Got it. And imaging beyond ultrasound.
Radiologic studies are vital. The first step recommended is often a simple chest X-ray that includes views of the neck, the cervical spine.
What can that show?
It's good for spotting obvious things like cervical ribs or maybe a big lump of bone from an old clavicle fracture. Basic but useful initial screening.
But it can't see everything.
No, it won't reliably show an abnormally shaped first rib or those fibrocartilaginous bands.
So what's next?
Computed tomography angiography CTA. This is really useful.
That's the one with the contrast dye.
Yes, it gives incredibly detailed 3D images of the blood vessels. They usually scan with the arm down by the side and then again with the arm raised, abducted.
To see the compression happening?
Exactly. It can pinpoint the compression site, show aneurysms, clots, irregularities in the artery wall, fixed stenosis, all of it. And the 3D views often mean you don't need the older, more invasive catheter angiography.
But again, just seeing compression on the CTA isn't enough.
Correct. The book is clear. Position-induced compression alone on a CTA doesn't automatically equal arterial TOS. It has to fit the whole clinical picture.
Are there alternatives to CTA, like MRA?
Magnetic resonance angiography is an option, yes. Doesn't use radiation. But Rutherford's notes it might be less sensitive than CTA. There were reports of higher false negative rates.
Meaning it might miss some cases.
Potentially. So a normal MRA doesn't completely rule it out if the clinical suspicion is high.
And catheter angiography, where they thread a tube in.
That used to be the gold standard, but now it's mainly used if they're planning an endovascular treatment like stenting or clot removal. It's actually less effective than CTA for seeing the structures causing the compression.
But it's good for seeing tiny clots.
Yes, it's still the best for visualizing emboli way down in the small arteries of the hand and fingers.
Any blood tests involved?
Not to diagnose arterial TOS itself, but blood tests are important to rule out other things that could cause similar symptoms, systemic issues like vasculitis or certain connective tissue disorders.
Right, the differential diagnosis. It sounds like there are quite a few mimics.
There are. Box 125.1 in the source lists a bunch.
Yeah.
Things like clots coming from the heart or the aorta, hypothenar hammer syndrome in the hand.
What's that?
It's repetitive trauma to the palm, like using your hand as a hammer, damaging an artery there. Also blood clotting disorders, different types of vasculitis, Takayasu's, giant cell arteritis.
Connective tissue disorders, too.
Yep, Marfan, Ehlers-Danlos, arterial dissection, just plain old atherosclerosis, Berger's disease, trauma, even specific things like shoulder artery issues in baseball pitchers from throwing.
So a lot to consider. Which brings up screening. Should we screen people without symptoms?
Generally, no. The text advises against it because of those high false positive rates with the compression maneuvers. You'd end up worrying a lot of healthy people.
But what about the other side if someone does have symptoms?
Ah, that's different. Evaluating the contralateral asymptomatic side might be reasonable. Why? Because bilateral cervical ribs aren't uncommon in TOS patients overall.
So you might find something brewing on the other side.
Potentially. And if they find significant arterial dilatation or intimal damage, even without symptoms, they might consider treatment to prevent future problems.
Okay, let's move to treatment then. If someone has symptomatic arterial TOS, what's the approach?
Unlike neurogenic TOS, where physical therapy is often the first line, our source says there's really no role for conservative treatment for symptomatic arterial TOS.
So waiting and seeing isn't usually an option if you have symptoms.
Not typically. However, for someone found incidentally to have compression, but no symptoms and no actual damage to the artery wall yet, watchful waiting with regular ultrasound checks might be okay.
And activity modification.
Definitely important, especially for athletes or anyone doing repetitive overhead motions. Reducing those compressive forces is key. Physical therapy might focus on modifying movement patterns.
What about treating abnormalities before symptoms start? If they find dilatation or something on the asymptomatic side?
That's a bit more nuanced. We don't fully know the natural history, how often these asymptomatic findings progress, but because the first symptom can be severe, like acute hand ischemia.
It might be better to intervene early.
The thinking often leans that way, yes. Treating documented arterial disease like dilatation or intimal damage before symptoms arise seems reasonable, especially in young, active people. The role of blood thinners here is less clear, though.
So for symptomatic patients or those with clear arterial damage, surgery is the main route. What are the goals of surgery?
3 main things. 1, relieve the compression. 2, remove the source of any potential emboli. 3, restore blood flow down the arm if it's compromised.
How do they relieve the compression?
That usually involves removing the offending structure. The cervical rib, anomalous first rib, fibrous band, whatever it is.
And the scalene muscle.
Yes, most experts also recommend dividing the anterior scalene muscle. And many advocate for routinely removing a portion of the first rib as well.
Why remove the first rib if the problem is a cervical rib?
Because the first rib forms the floor of that outlet space, and it's where compressive muscles and bands often attach. Removing it widens the space significantly and helps prevent recurrence.
Okay, so decompression is key. What about removing the embolus source?
If there's an aneurysm or a segment of artery with significant intimal damage and maybe clot inside, that needs to be dealt with. Usually means resecting that damaged segment and reconstructing the artery.
And restoring distal flow.
If clots have already gone down the arm, you need to address that. Options include thrombolysis, clot-busting drugs, thromboembolectomy, surgically removing clots, or sometimes bypass surgery further down the arm.
Does the artery always need repair after decompression?
Not necessarily. It's an individualized decision. Sometimes, if it's just post-stenotic dilatation without major damage, relieving the compression might be enough, and the artery might remodel over time. But it's not guaranteed.
What about aneurysms?
Symptomatic aneurysms generally need repair because the risk of further emboli is high. And even if a subclavian artery isn't causing symptoms at rest, repair might be considered in active people due to arm fatigue or that small stroke risk.
Is there a way to classify the severity to guide treatment?
Yes. The Tramger classification is mentioned. Stage 1 is basically compression with minor dilatation. No major damage treatment is usually just decompression.
Stage 2.
That involves an aneurysm, intimal damage, maybe some clot stuck to the wall, needs decompression and artery reconstruction.
And Stage 3.
That's when emboli have already traveled downstream, causing ischemia, needs clot removal, thrombolysis or embolectomy, plus decompression and vascular reconstruction.
So summarizing treatment. Surgery for anyone symptomatic or with clear arterial damage. Monitor if asymptomatic with just compression.
Pretty much sums it up. And remember, the most common bony issue is that cervical rib, about 3/5 of cases. But abnormal first ribs, fracture calluses, bands are also possibilities.
Let's talk about the surgery itself. What are the approaches?
The main goal is always decompression first. Removing the rib or band, releasing the scalene muscle. Most favor taking out part of the first rib too, as we discussed.
How do they get in there?
3 main ways. Transaxillary, through the armpit, good for first rib removal, but tricky for vascular repair. Supraclavicular, above the collarbone, often preferred if vascular reconstruction is needed. And sometimes infraclavicular, below the collarbone, or a combination.
When would they need the infraclavicular approach?
Maybe for a very large aneurysm, or if the damage extends way down under the clavicle. Sometimes they use one long incision, combining supraclavicular and infraclavicular access.
And if they replace part of the artery, what do they use?
Usually a graft. Could be a vein taken from the patient's leg, a cryopreserved donor artery, or a synthetic prosthetic graft. Need to be careful with longer grafts to avoid kinks.
Are there important technical points during the surgery?
Absolutely. Protecting nerves is critical. The phrenic nerve runs right over the anterior scalene muscle, so it needs careful mobilization. The long thoracic nerve is near the middle scalene, and the brachial plexus nerves are right there too.
And removing the first rib.
Requires careful dissection to free it from surrounding tissues before cutting it, often using special tools. It's delicate work in a crowded space.
What about less invasive options? Endovascular.
There have been some reports of using stents combined with surgical decompression, but the text suggests long-term results aren't as well established. There are risks like stent fracture, collapse, restenosis, thrombosis.
So it likely needs lifelong monitoring.
Probably. Open surgery is still generally the standard for repair in this situation.
And for Stage 3, getting clots out distally.
Right. Embolectomy is common, sometimes needing another incision down in the arm or hand. If it's chronic embolization, a distal bypass might be needed. Thrombolysis could be an option too, especially for smaller clots or milder ischemia.
After surgery, what's involved?
Physical therapy is important for regaining shoulder and arm motion, and regular follow-up with physical exams and vascular lab studies like duplex ultrasound to monitor the repair.
How is success measured?
Primarily by symptom relief, no recurrence, keeping bypasses open, patency, and limb salvage saving the arm and hand.
And the results are generally good?
Yes. Rates of symptom relief and bypass patency are reported to be high. Limb salvage is excellent for stages 1 and 2. Stage 3 carries a small risk of finger amputation if distal damage was severe.
Does the outcome depend on anything specific?
A lot depends on the state of the blood vessels further down the arm, the outflow. If that's good, prognosis is better. Decompression alone often works well for stage 1, and the artery widening can even regress. But compromised outflow makes things tougher. Still, overall functional improvement is usually significant.
What about complications? Surgery in that area sounds tricky.
It is complex anatomy. Thankfully, operative mortality is very low. Morbidity, complications can happen, though.
Like what?
Things related to nearby structures. Pneumothorax, collapsed lung, hemothorax, blood in chest, chyle leak, lymphatic fluid, nerve injuries, brachial plexus, phrenic, long thoracic, vascular injury. Horner's syndrome is rare.
What kind of rates are we talking?
Varies in studies, maybe 7% up to 40% overall morbidity.
Yeah.
Pleural entry, getting into the lung space, and temporary nerve issues seem most common.
Okay, so wrapping this up, what's the main takeaway?
I think it's that arterial TOS, while it is rare, is definitely a serious condition. It's strongly linked to those bone abnormalities, usually needs careful diagnosis, and often requires surgery to head off potentially bad outcomes like hand ischemia or even stroke.
Yeah, it really underscores that connection between our anatomy, how we're built, and how things function, especially our vascular system. Understanding those causes and treatments from the source material seems crucial.
Absolutely. And it leaves you with something to think about, doesn't it?
Yeah.
If these relatively subtle anatomical variations can cause such significant vascular problems, what other silent physical traits might we have that could have unexpected health consequences down the line?
That's a fascinating thought, that link between structure and function. Definitely something worth pondering.